I want you to picture a specific patient. Let's call him John.
Okay.
At 45, maybe a little soft around the middle, the classic dad bod, but nothing that screams medical emergency.
Right, the typical guy you see in primary care every day.
Exactly. So you run the standard workup. His fasting glucose is, say, 95. Hemoglobin A1C is 5.4.
All normal.
Totally normal. Even his LDL cholesterol is sitting at 100. By every traditional metric we use, John is the picture of health. Gets a pat on the back and a see you next year.
And that moment, that see you next year, is so often a missed opportunity of catastrophic proportions. Because while John looks fine on paper, he is actually metabolically on fire.
That is the paradox we are exploring today. We're looking at why these standard labs are, well, they're essentially lying to us about early-stage metabolic disease. And we're doing a deep dive into the tool that exposes the truth, the lipoprotein insulin resistance index, or LPIR.
This is such a pivotal topic because it forces us to shift our entire mental model. We have to stop thinking about chemical mass, which is just, weighing how much cholesterol is in the blood, and start thinking about metabolic architecture.
Metabolic architecture.
We're looking at the structure, the size, and the quality of the particles themselves.
I like that. Metabolic architecture. That's the theme. We've got a lot of ground to cover. The failure of the old markers, the physics of NMR technology, the specific scoring system.
And the practical side.
And we are going to get very granular on the logistics of actually ordering this in Hawaii because, as our research shows, that is a landscape just full of potholes.
It is, but navigating it is worth it.
Right.
Because we aren't just talking about better data. We are talking about predicting diabetes 8 years before it happens.
8 years. Okay, so let's start there with the why. Why are we missing guys like John? If his A1C is normal, doesn't that mean his glucose control is fine?
It means his glucose control is fine right now, but A1C and fasting plasma glucose they're lagging indicators.
Lagging how?
By definition, they only rise after your body's compensatory mechanisms have failed. They are essentially autopsy reports for your metabolism.
So the body is struggling to keep that number normal, but the test only shows the result, not the struggle.
Exactly. The beta cells in the pancreas can be overworking, pumping out massive amounts of insulin to overcome resistance for a decade.
A decade.
For over a decade before the glucose finally creeps up. If you wait for the A1C to rise, you're looking at the car crash after it has already happened. We want to see the car swerving.
Now, the savvy clinician listening is going to say, okay, but I have HOMA-IR.
Sure.
That's the standard calculation for insulin resistance fasting, insulin times glucose. Isn't that enough?
HOMA-IR is, okay, it's better than nothing. But here is the nuance that often gets missed. HOMA-IR fluctuates wildly.
Okay.
If you had a stressful drive to the clinic or a bad night's sleep, your HOMA can spike. More importantly, it primarily reflects hepatic insulin resistance, what's happening in the liver.
Just the liver. But insulin resistance isn't just a liver problem.
It's not.
It's a muscle problem. It's a fat tissue problem.
Precisely. We need the peripheral picture. And this is where LPIR just separates itself. It captures the resistance in the liver and the periphery.
And it's more stable.
Much more stable. And when you validate it against the gold standard, the hyperinsulinemic euglycemic clamp LPIR correlates significantly better than, say, the standard triglyceride to HDL ratio.
I see that term, the clamp, in the literature all the time. It sounds medieval. What does it actually involve?
It's practically torture. You hook the patient up to 2 IVs. One pumps insulin at a steady rate, the other pumps glucose.
Okay.
And you have to constantly adjust the glucose to keep their blood sugar stable euglycemic while you're blasting them with insulin. It takes hours, it's expensive, and you absolutely cannot do it in a busy clinic.
So finding a blood test that acts as a reliable surrogate for that ordeal is the holy grail.
It is. The correlation is negative 0.53, which in the world of biomarkers, that's a very strong signal. It lets us see that peripheral resistance without the IVs.
Let's get into the engine room here. How does this test actually work? Most of us are used to enzymatic assays. You mix blood with a chemical, it changes color.
Right, and a machine reads the density. That gives you mass milligrams per deciliter. But LPIR uses NMR.
Nuclear magnetic resonance spectroscopy.
Right, this is totally different physics. Imagine a choir singing. A standard cholesterol test is like putting the whole choir on a scale and saying, the choir weighs 5,000 pounds.
Okay, that tells you the mass.
It tells you the mass. It tells you nothing about who is singing.
And NMR.
NMR is like listening to the song. You place the plasma in a magnetic field, And the lipid particles emit radiofrequency signals. But here is the cool part. The frequency changes based on the size of the particle.
So the basses sound different from the sopranos.
That's a perfect analogy. The machine can distinguish a large, fluffy LDL particle from a small, dense, dangerous one just by listening to it.
It's counting, not weighing.
Exactly. It creates a spectral graph, it counts the number of particles in unmol, and it measures their diameter. And this is crucial because insulin resistance causes a very specific structural remodeling of these particles. The architecture changes.
Walk us through that remodeling. Why does my cholesterol change shape just because my cells aren't listening to insulin?
It's a domino effect. It starts in the fat cells. When you are insulin resistant, it fails to suppress lipolysis. Basically, the stop signal for breaking down fat is broken.
So your fat cells are just leaking fatty acids.
They're flooding the liver with free fatty acids. The liver, trying to cope, packages this fat into large VLDL particles, very low-density lipoprotein.
So step one is the liver launching these massive cargo-heavy VLDL ships.
Correct. And because the body isn't clearing them efficiently, they linger in the bloodstream. This is where a protein called CETP, cholesterol ester transfer protein, enters the chat.
CETP.
I like to think of CETP as a confused logistics manager. It sees these VLDL ships full of triglycerides and starts swapping cargo with the other particles.
Swapping. You mean it's moving fat into the LDL?
It takes triglycerides out of the VLDL and shoves them into your LDL and your HDL particles. In exchange, it moves cholesterol esters back to the VLDL. It's a bad trade.
That sounds like a bad trade.
It is. Now, your LDL and HDL are bloated with fat they shouldn't have. Another enzyme comes along, strips that fat out, and the particles, they collapse.
They implode.
They shrink. You end up with small, dense LDL, which is like a pellet that can penetrate the artery wall easily, and small HDL, which sheds its protective proteins and becomes dysfunctional. It's a pro-inflammatory state.
So the LPIR score is essentially an algorithm that's looking at the wreckage of this entire process.
It's looking at the footprint of that collision.
Okay.
And the score runs from 0 to 100 based on 6 specific weighted parameters.
Let's run through the architectural 6. What specifically is the algorithm counting?
It's 3 pairs. First, VLDL. You have high counts of large VLDL and an increase in overall VLDL size. Both drive the score up.
Because that indicates the liver is flooded with fat.
Exactly. Second pair is LDL. You have a high count of small LDL particles, and the overall LDL diameter decreases. Smaller is worse, so that drives the score up.
Okay, that makes sense. And the HDL.
The third pair. You lose your large HDL particles, the protective ones, and the overall HDL diameter shrinks. So large VLDL, small LDL, small HDL, that is the triad of insulin resistance.
The algorithm crunches these 6 inputs and spits out a single number, 0 to 100. If I'm a clinician holding this report, what's the danger zone?
The threshold is 68. A score of 0 to 45 is optimal. You are insulin sensitive.
Yeah, above that.
46 to 67 is the gray zone. But if a patient is above 68, they are high risk.
But when we say risk, we aren't just waving our hands. The data from the PREVEN study is genuinely startling.
It is hard to overstate the PREVEN findings. They followed nearly 6,000 non-diabetic people for about 7 years. They found that people in the top quartile of LPIR scores had a 10.18-fold increased hazard ratio for developing diabetes.
Hold on. A 10-fold increase. That's massive. That's in the realm of smoking risk.
It is enormous, and the skeptics will say, well, those people probably had high glucose already.
Sure.
But the researchers adjusted for that. They adjusted for age, BMI, fasting glucose, family history. Even with all those factors leveled out, the risk was still 3 times higher for the high LPIR group.
So it's finding the people that the other tests miss.
It predicts diabetes up to 8 years in advance. It buys you a decade of intervention time. And it's not just diabetes.
Right, cardiovascular disease.
Yes. In women under 55, the LPIR score was a stronger predictor of cardiovascular disease than LDL cholesterol, ApoB, or even systolic blood pressure.
That's a key demographic because heart disease in younger women is notoriously difficult to catch early.
It is. It tells us that metabolic dysfunction is driving vascular damage long before the cholesterol mass looks high.
This connects back to a specific phenotype I want to highlight. The lean insulin-resistant patient, the so-called TOFI, thin outside, fat inside.
This is where the BMI chart fails us completely. The MISSIS study highlighted this. They found that people with a BMI under 24 medically lean could still have LPIR scores over 50.
So you can't just look at a patient and say, you're skinny, you're safe.
Absolutely not. Visceral fat, the fat packed around the organs, Doesn't always show up on the scale, but it screams on an LPIR test. If you rely on BMI, you leave these patients unprotected until they have a heart attack.
Okay, so we've identified the problem. John has a score of 75. He's in the red. What do we do? And I suspect the answer isn't just throw a statin at it.
No, this is what we call the statin paradox. We love statins for lowering LDL cholesterol mass. They are fantastic at that, dropping particle counts by 40% or more. But if you look at the rosuvastatin trials, specifically the Jupiter analysis, the drug barely touched the LPIR score. It went down by maybe 3%.
That is a crucial distinction for the listener. You can fix the amount of cholesterol without fixing the metabolic engine that is remodeling it.
Exactly. You are cleaning up the spill, but not fixing the leak. The insulin resistance is still there. So if the LPIR is high, you need different tools. Lifestyle is the heavy lifter.
Diet and exercise.
Weight loss and carb restriction move the needle fast. But pharmacologically, we need to look at PPAR alpha agonists.
Fibrates.
They are far superior to statins for this specific problem because they improve insulin sensitivity and increase particle size. They fluff up the LDL and HDL.
What about supplements? High-dose omega-3s. We hear a lot about berberine.
High-dose omega-3s, we're talking 2 to 4 grams, also help, but head-to-head, fibrates win on the score. And berberine is fascinating. It activates similar pathways to metformin. It works. But I have to drop a warning here about a supplement that's very popular in the fitness community.
Which one?
Branched-chain amino acids, or BCAAs.
The stuff everyone drinks at the gym to build muscle?
The very same. Bodybuilders love them for hypertrophy, but we have strong data showing that high circulating levels of BCAAs are linked to worsening insulin resistance.
That is completely counterintuitive. You think you're taking a health supplement.
But you might be throwing gas on the metabolic fire. If you have a high LPIR score, chugging BCAA shakes is likely the wrong move. You need to clear the substrate backlog, not add to it.
That is a nugget worth the price of admission right there. Now, I want to pivot to the practical side. We reviewed the landscape for ordering these tests, specifically in Hawaii, and it is a perfect case study in how logistics can strangle innovation.
It's a mess. It really is. If you're a practitioner in Honolulu or Iwa Beach, you basically have 2 main paths, and they lead to very different results. It all depends on which lab logo is on the door.
Let's break it down. You have Labcorp, and you have Clinical Labs of Hawaii.
Right. Labcorp is the easy path here. They own the proprietary algorithm for the 0-100 IPIR score. It's test number 884,000. You order it, you get the graph, you see the risk. Simple.
But Clinical Labs is everywhere in the islands. They're much more common.
They are dominant. But, and this is a huge caveat, Clinical Labs sends their advanced testing to ARUP laboratories. They offer a test called LipoFit.
And LipoFit is different.
It uses NMR. It gives you the particle counts, the small LDL, the large VLDL. But it does not give you the 0-100 LPIR score.
Because they don't have the license for the algorithm.
Exactly. So the doctor gets a page full of raw numbers. They have to look at it and interpret the pattern themselves. Okay, high VLDL, small LDL. This looks like insulin resistance. It requires a much higher level of liquid literacy.
It puts the burden on the doctor to be the algorithm.
It does. And then you have the insurance wall.
The eternal struggle.
In Hawaii, HMSA is pretty strict. They scrutinize these cardiovascular risk panels.
Right.
You usually need to document high risk or failed standard therapy to get it covered. But Kaiser,
We saw the policy update, effective May 2026.
it's explicit. They consider multi-biomarker panels not medically necessary. Their argument is that there's insufficient evidence that knowing the particle size actually changes long-term outcomes compared to standard panels.
That's a difficult position to defend when we just discussed that it predicts diabetes 8 years early.
It's an economic versus ethical debate. The payers want randomized controlled trials proving that treating the score specifically prevents the heart attack. That takes decades to prove. Meanwhile, we have patients converting to diabetes who could have been warned.
Before we wrap up logistics, there's one critical piece of patient prep. This isn't a test you can just pop in for after lunch.
No. Pre-analytical error will ruin this test faster than anything. You need a strict 8 to 12-hour fast, water only. But the one everyone forgets is the alcohol rule.
The no happy hour clause.
You cannot drink alcohol for 24 to 48 hours before the draw. Alcohol causes an acute spike in triglycerides.
Of course.
If you have a glass of wine at dinner and get tested the next morning, your VLDL measurement will be garbage and the score will be artificially inflated.
So you might diagnose a patient with severe insulin resistance when they really just had a Merlot.
Exactly. And the sample handling is just as fragile. It has to be spun centrifuged within 2 hours. If the courier gets stuck in traffic on the H1 and that blood sits in a hot car all afternoon,
The results are invalid.
the lipoproteins degrade, the results are invalid.
It's a powerful tool, but it requires precision handling. Looking forward, is this technology evolving? We're just scratching the surface of what NMR can do.
The beauty of NMR is that once you scan the sample, the data is all there. We are now seeing markers like glycate, which is a marker of systemic inflammation being pulled from the same scan. We can measure those BCAs we talked about. We are moving toward a comprehensive cardiovascular profiling from a single tube of blood.
So we're moving from a snapshot to a high-definition movie of the patient's metabolism.
That's the goal, to see the storm before it hits.
So if we distill this deep dive down to a single takeaway for the listener, what is it?
For me, it's about the metabolic compass. We have an obligation to look deeper. If you have a patient who is normal on paper but has a family history or carries weight in the middle or just doesn't feel right, don't stop at the A1C.
Go further.
Go further. The LPIR score is the smoke detector. Whether insurance pays for it or not, knowing that information changes the conversation. It shifts us from treating disease to preserving health.
And that is the shift that matters. The architecture of our metabolism tells a story that chemical mass simply can't. Next time you see that normal lab report, ask yourself, what's happening to the particles?
Remember, you can't manage what you don't measure.
And sometimes, what you don't measure is exactly what kills you. Thanks for joining us on this deep dive. Stay curious.